We are so honored today to welcome Dr. Jessica Zitter, who is a nationally known expert in both palliative care and critical care. And she has written extensively. She wrote a book called Extreme Measures, which is in your resources. Incredible book. Has also written for the New York Times, the Atlantic, the Washington Post, Time Magazine. She has also been involved in the production of 2 documentaries, which we're going to see the trailers of today, that discuss difficult decisions that are made at the end of life and the role of caregiver burden. So we would never get such a famous and fancy speaker for our webinar if it weren't for the fact that Jessie and I have known each other for 30 years. We were interns and residents together at Brigham and Women's Hospital. So I have followed with great interest her career, and she's now coming to us from Oakland, California, where she's an attending at Highland Hospital and working on discussing and educating the community and other physicians about how best to proceed with conversations about end-of-life care. And we're going to talk today about probably the most important conversation any of us will ever have with our loved ones, with ourselves, with our physicians. And that's how to achieve, to be proactive and planful as we approach the end of life. So, without further ado, Jessica, welcome to the Lown webinar.
Oh, I'm so glad to be here. So glad to be here with you. Thanks.
And last time we had you physically here in our office, which was a few years ago, you were consulting for us on the Good Life Project. And I know that a lot of people in the audience today have participated in that. And it's a study that we did where we taught ourselves as physicians how to do a better job of having a conversation with our patients about what were their goals and their priorities as they approached end of life. So that was how we first got you involved in this conversation. But maybe you can tell us a little bit about your connection to the Lown Group, because I know that you write about that in your book as well.
Oh my goodness. Well, it's so funny that we didn't even think to include that as part of the piece until just right before that. I said, oh my gosh, I have a long relationship with the Lown Group that predates Dara's being a part of the Lown Group. I really remember when we were cardiology residents. I wasn't a cardiology. Sorry, when we were residents, we were medical residents, and we had these 2 groups, the 2 cardiology groups. There was the Lown cardiologist, and there were the hospital cardiologists. And I remember I write a lot about in my book my perceptions of these 2 different groups and how it's changed, how my perceptions in the 90s when I first came and had interaction with Lown cardiology, and my perceptions now as a palliative care physician who really values and has a very different philosophy from that which I was trained with. When we were trained as interns and residents at that wonderful institution, the Brigham and Women's Hospital, learning the best of the best healthcare, the best of the best organ management, etc., we were also taught something else between the pages, the hidden curriculum as we call it. And that was that to do more to people, to do more interventions, to use more fancy technologies was a sign of being a better doctor. It wasn't written in any textbook, but it was what we incorporated, what we absorbed. And so we had these 2 cardiology groups. We had the very intensive Brigham cardiologists who were always doing procedures and not talking very much to patients. And then we had the Lown cardiologists. I remember calling them the Lownies, which I'm embarrassed to say at the time was maybe a little bit of a brush off. They were the more kind and touchy-feely, but less interventionalist. They would talk to you first. And I remember feeling at the time in the 90s that was somehow just a little bit less than. And it really took me 30 years to learn that it was completely the opposite. And when I wrote my book, I really hearkened back as I was writing this book about my new approach to healthcare, which is really about prioritizing the patient's values and preferences, putting the patient at the center, that I remembered this contrast between these 2 cardiology groups and how I used to feel that Lown was here and the Brigham cardiologists were here, and I flipped it completely on its head, and I write a lot about that in my book. And also Bernie Lown in general, who really created the whole philosophy of the Lown cardiology group, where, Bernie Lown was the first person who did this thing called chair therapy, and you as cardiologists know about this better than I do, but he said, wait a minute, get these people out of bed. Don't do things to them, and get them out of bed and get them just moving a little bit. He sort of this preventative approach, and he was really, in a way, lambasted for that. He really was given a hard time for doing this thing that really was about less technology, but common sense and patient-centeredness. And I think, anyways, I'm babbling, but yes, I have a long relationship.
No, and currently in the Lown group, so we have Dr. Charles Blatt, Dr. Shmuel Ravid, Dr. Brian Bilchik, who were all Lown fellows at the time. And when I was a Brigham cardiology fellow working with Brian Bilchik, you know, even though I was of that Brigham culture, whenever I had a friend or family member who needed a cardiologist, I sent them to the Lown group. And when I came back to Boston, and I said, I'll never take a job at the Brigham, but if I could get a job at the Lown group, I'm coming back to Boston.
And I sent my sister-in-law to you.
Yes, exactly. So there we are, 30 years later, everything has changed. So, you know, I want to start zooming in a little bit on the acute moment of intensive care end of death that we all think about when we think of end of life. And then maybe we can step back and take a broader lens at what leads up to that moment and the role of the caregiver and the family and being a burden. So we have, you know, we've gotten questions from the audience in advance, and we welcome you all in the audience to submit questions as we go along. But I would love to start by looking at the trailer for Extremists, which is that short Netflix documentary that you made, and perhaps use that as a starting point to talk. And can you set the stage for us about what this trailer is?
Yes. So this is a 24-minute film that's on Netflix that you can watch if you have Netflix, that basically follows me around. And remember, put context to it. I'm an ICU doctor, but I'm also a palliative care doctor. So what you're seeing there in the intensive care, in those interactions between me and these patients in the intensive care unit, you have to understand that it's not a typical ICU approach. It's an ICU blended with palliative care approach. But you'll see in this trailer, and the film in general is about trying to help people who are at the end of their organ function. They're really coming into the ICU to die. They've never had conversations. Nobody's had a conversation with them about their preferences and values. And here they are, and I'm meeting them for the first time. And what is the right thing to do at that moment? First of all, let's step back and say, that's not an ideal situation. People shouldn't be coming to the ICU, and the first time they're talking about preferences and values is either on a ventilator or as they're going into organ failure. That's not the way we want to do things. We want to step it back and do advanced care planning. But this film is, if anything, it's a real call to plan in advance. Don't let this happen at the end. But if it's happening at the end, what are some strategies that we can do to try to have these conversations about what your preferences and values, so we know what to do even in those late moments. So that's really what this is.
Perfect. Thank you.
Selena, can you squeeze my hand?
Here's the reality. We're all going to die. Everyone standing in this room is going to die one day. And it's good to have a little bit of a say in how.
I want to make sure that she knows that we've explored all the options.
Every day, people are attached permanently to machines. My concern is we're going to cause more suffering without likely benefit. The other approach is let her pass naturally.
It would feel like murder to pull her life support.
If I had to make the decision for myself, then take me off, and if I breathe on my own, then that's fine. That's God will.
Amen.
How would you feel if you were not getting better on a breathing machine?
Then I don't want to be on a breathing machine.
It's his decision, but I don't want to see him go.
We're going to support you through this.
Pull the crash cart in.
She won't wake up from this in a meaningful way.
Knowing at some point you got to get to that reality, and now it's here.
All right. Wow. So these are some situations where people are clearly facing some really tough decisions. And I think the question that comes up, especially when someone's facing an immediate choice between going on a ventilator versus dying, a lot of patients and family members would say, well, why not just give it a try? What's wrong with thinking that way?
Yeah. It's really a good question. And I think the only way to answer it is for people to have a full, fleshed out understanding of what the other side is. It's not like just buying a lottery ticket where you're out $5 if you don't win. What the downside of an unsuccessful trial in the intensive care unit is suffering, a protracted death, and life and dying on a machine. And in some people, I think many people think is worse, is the idea of getting connected permanently to those machines, which happens at rates that you would be very surprised at, very high rates. More and more people are getting sent to long-term acute care facilities attached to machines permanently with trachs and feeding tubes. And they go and then they come in and out of the hospital with a variety of different kinds of infections, never really achieving independence again. And that is an epidemic that we need to know about, and people, when they're making these decisions, need to know what is the downside of deciding to opt into those what I call the end of life conveyor belt, if it won't be successful, is some very grim things that you deserve and should know about before you make your choice.
So can you give us an example of perhaps a patient that you've taken care of who wasn't able to have that conversation ahead of time and ended up on this conveyor belt, and how that affected them or their family?
Yeah, I mean, the first thing that comes to mind is a story. Sometimes you can actually verbally have a conversation, but you're so emotionally overwhelmed by the environment that a conversation it's not helpful. So I'm thinking of a patient that I took care of who had very end stage HIV, who had not told his mother. He had only his mother in his life, and he never told her about it. He never took any medications. He was very he just didn't want to deal with it. And then he came into our ICU with PCP pneumonia, PJP pneumonia, and very, very, very at the end. And he was getting worse and worse. And I knew that given the state of his lungs, that if we got to a point where he went on a breathing machine, that it was almost impossible he would ever come off of that breathing machine. And I wanted to say to this man, is this an outcome that you are okay with, dying on a machine? Because some people are okay with that. Would you be okay with that? Or is this so unacceptable to you that we should really focus on comfort and keeping you calm and, not putting the tube? And we couldn't have that conversation, both because he was so scared and because he was also avoidant of this diagnosis, so he couldn't really talk about it. So there were many things that happened that we just never, and so I ended up intubating him, and he died on the breathing machine within a few hours. That's just one of so many examples, so many.
So many. So when is the right time to have a conversation like this? Because, I remember when we as a group of cardiologists decided to train in how to have these conversations, there was a sense like, I'm just having a routine visit with my patient who has stable heart disease, stable AFib heart failure. If I bring this up, it's going to be frightening. It's going to be inappropriate. It's going to imply that I think they're about to die. What's the right time, either for a patient or for a doctor or for a family member, to bring this up? Hey, Mom, we ought to talk about this. Right.
Such an important question. And at the root of this question, not only for the doctor-patient relationship, but also for the mother-daughter relationship, is a fear of death, a lack of acknowledgement in our society that death happens. And it's pretty American, although I would say that a lot of other countries are following in our footsteps. We really believe that somehow we think that death is optional. And the truth is, we know we're all going to die, but we just don't want to acknowledge that. And the problem with it is, I can tell you, and I know you can too, that from where I stand and the work that I do, I see profound destruction and devastation from that avoidance. And it's like any psychologist would say to you, if you're going to avoid certain topics, they're going to come and bite you in the end. And I think that the answer to the question is, death conversations should be a part of life. They should happen early. I believe every 18-year-old should have some death education, should have had death education in high school. I believe that an 18-year-old should complete their first advance directive and start to think about some of these things. I believe that families, marriages, mothers and daughters should be having these conversations along the way, thinking, well, what are your preferences about
how would you feel about what happened to Aunt Anne over there when she had her stroke? Mom, would that be okay with you? So that it becomes a normal part of the relationship of the family. It becomes a normal part of the relationship of the healthcare practice. And we're not sitting and tiptoeing around something that is causing terrible damage because we're not talking about it.
You know, it's so interesting that you say that, because when we did start these conversations, we all came to each other and said, huh, that patient said, thank you. His wife thanked me. That it's very true that many patients, especially who come to a cardiology practice, but everyone has thought about it, right? Everyone has thought about their own death. And just because we don't talk about it doesn't mean that we don't think about it. And I love the way that you say, like, normalize it. Make that just something that we talk about as a matter of life, and it's a matter of death, because it is going to happen.
And yes, but that's we're talking about sort of normalizing it in healthy culture, pre-morbidity. But I want to say the same thing for people who are either hospitalized or have serious organ damage or you know, organ dysfunction, CHF, congestive heart failure, all, you know, whatever, COPD. People who have serious illness know that they have serious illness. They know that their bodies are not what they used to be. And for us to avoid having that conversation with them takes away a certain amount of control that they have. It takes that, if everyone's pretending that they're not sick, that's playing a number on those people, because then they feel like, maybe I'm not trying hard enough, maybe I'm just being too morbid. When we come to patients who are sick and acknowledge that, and acknowledge that their bodies aren't working the way they want, and then say, so let's talk about the different scenarios that we want you to be prepared for. There is a relief that comes with that acknowledgement. Yes.
So can you give an example of a conversation you've had that went well, that was had early on in a relationship before you got to the point of holding a breathing tube over their head?
Oh my gosh. I mean, so many. I mean, it depends if it's, you know, with family, with friends. I think that as a palliative care doctor, like, let's just talk about walking around in the hospital. I too have those fears every time I engage and enter into a conversation with people about, you know, you're really sick. Let's talk about that. I'm always afraid that someone's going to look at me and say, what? Or get out. I don't want you as my doctor. I need that doctor. That doctor's more positive. I have to tell you that it almost never happens. If you can come in and learn what we call these primary palliative care skills, but really they're just good communication skills of really asking people what they understand, and then filling in the gaps for them, which is something we learn how to do in palliative care. You will find that the vast majority of people actually want to talk about it and know a lot more about their situation than you think they do, and really appreciate you talking to them about it so that they can feel some control.
And if you're a patient and you're thinking about these things and your doctor has never brought it up, how would you suggest to someone to bring it up with their doctor?
Yeah, great question. A really great question. Very important, because the truth is we're not evolved yet, you know, as a medical, and I'm going to blame doctors. I'm not really pulling nurses and social work. I'm going to talk about doctors, because the way the current system works, who is the person who's expected and who expects to give news, good and bad? It's the doctor. And the doctors are trained in the philosophy that I described in the 90s that I had, which is, if this person's going to die, it's because I failed. And so there will be many doctors that you will come across, not at the Lown cardiology group, but in many other places, who won't want to talk to you about this. Or if you bring it up, say, oh, you're not ready for that conversation yet. Oh, no, we're not ready for hospice. Oh, no, we're not ready for palliative care. And that is a disservice. That is depriving you of the right to learn more and to get more sense of what your options are, and to bring yourself into the conversation and tell them what is important to you. So they're depriving you of rights that you have to have them be patient-centered. And so what you can do as a patient is you can insist and say, doctor, you might have to help them, because I'm sorry to say, but they may not be very evolved. You may have to say to them, I know you don't have a crystal ball. I'm not asking you to tell me 100%, but I want to know what you think. I'm forgiving you. You don't have to be perfect. Just please tell me your basic thoughts. And then please tell me your basic sense of what my options are and what those options would be. You can encourage your doctor to not be so guarded and afraid of telling you something that's not perfectly true by saying, I understand that there's no crystal balls here, but I do want to know your opinion. And if you can't get it from that doctor and they won't let you bring in palliative care, then you may need to switch doctors.
Yes, I think certain specialties may be even more resistant to that conversation than others. And I know we did have a comment submitted about oncologists, for example, who tend to always have one more chemotherapy in their back pocket and one more option. And they notoriously and understandably are reluctant to say, okay, you know what, I got nothing else for you. And it's not that they have nothing else, but maybe what they have left is not worth the trouble or pain or suffering that it's going to cause. Because for something like chemotherapy, it can be quite uncomfortable.
We're doing a podcast series, and one of the podcast episodes that we're doing is with, James Tulsky at the Dana-Farber, who's a care doctor. And he, I think, does one of the best explanations about what's going on there. Like, what is happening for these oncologists? He may be a little bit kinder than I would be, but his explanation is these doctors really care about their patients. They get really attached to their patients, and they just want to feel like they can provide everything that's needed for their patients. So that the idea of bringing palliative care in makes them feel like they're less than, or they're not doing everything, or they're not good enough, which is a really big problem, because the American Society of Clinical Oncology in 2012 made a recommendation that every patient with serious cancer should have a palliative care consultation side by side. They could live for years and years and years, but they should still have palliative care following them. And that almost never happens. So I think we do have a problem with the oncology world. I think in some ways, oncology is a place where palliative care is making the most inroads, but we still have a lot of work to do.
Can you say a little bit of the role of a palliative care specialist? In oncology or in heart failure, they use this as well. Some people don't know what that is.
So what is palliative care? To palliate, palliare is a Latin verb that means to cloak. And it's the vision of somebody coming in and just cloaking a person, taking care of them, sheltering them from any suffering, whether it's emotional, psychological, informational, physical. And really, that is what we're trained to do in palliative care. We are trained very rigorously in communicating and helping people with patient-centered, kind and compassionate communication, with processing the emotions that are so much a part of serious illness, being there with patients and their families to help them go through this very complicated time, make the right decisions for them. We probably have some of the best communication training that's out there, just because we practice it the way you practice an intervention, or we practice putting in a Quinton catheter. So that's one thing. And then of course, all the symptom management. We are versed in, in really managing any kind of symptom, whether it be physical, emotional, psychological, etc. And that's what we can do. And we really, I think, should be involved with this serious illness teams that are taking care of patients with CHF, with cardiomyopathies, with whatever, because we can really add a lot.
Okay, and what's the difference then between palliative care and hospice care?
Oh, totally. Okay, this is a really important thing, because it's created for us a marketing problem. Hospice, which is a wonderful service, is a subset of palliative care. It's a subset. It's for patients with serious illness. Palliative care, patients can live for years and benefit from palliative care. In fact, we know that in many situations, patients actually live longer.
Yep.
Hospice is for people who are determined by their doctor, the small subset of patients who would benefit from palliative care, the patients who are actually 6 months away from death, as determined by their doctors. And again, there are several studies, particularly in the oncology world, that shows that, that if you do bring in hospice, patients also live longer than if they continue down the full court press treatment. So it's a subset. Hospice is patients who are dying. Palliative care, you don't have to be dying to get palliative care to benefit from palliative care.
And so with hospice, what happens when you bring hospice in?
Hospice is a wonderful service that is essentially functions like a palliative care team that you would see in the hospital or in the clinic, where we have, and this is actually an important part of what is palliative care. It's interprofessional. And interprofessional means that it's not just a doctor at the top making all the decision. It's a group of equal and separate specialists, a social worker, a chaplain, a nurse, a doctor, and we all come in and we are basically looking at the patient from this complete 360-degree angle to attend to everything that might be falling through the cracks. The same thing for hospice. In an ideal world, and not all hospices function this way, but in an ideal world, in an ideal hospice scenario, most of those patients are taken care of at home, and they would get the same interprofessional approach to this patient and family that you would get from these palliative care teams. Did I answer that question, or did I miss it?
Yeah, no. I think it's a lot of people have had experience with family members who might have gone through hospice, and I'd say almost always positive results, right? So if a person is deemed by their doctor to have perhaps 6 months or less to live, the way I've always understood it, and please correct me if I'm wrong, is you transition from trying to cure to trying to make the rest of the time as comfortable and as fulfilling and full as it can be.
That's right.
So usually you stop interventions that might be life-saving but cause suffering. So you might stop, for example, chemotherapy. You might not go back to the hospital. You might receive fluids. If you're dehydrated, you might receive antibiotics. If you have an infection, you might receive oxygen if you need it, right? All those things can still be part of hospice, especially if they foster comfort. But the focus is no longer on prolonging survival. The focus is on comfort.
That's right. And you just brought up a really important point, which is, I said you can only qualify for hospice if you are considered to be 6 months away from death. You also can only qualify for hospice for the most part if you have decided you do not want to continue disease-focused treatments like chemotherapies, et cetera. So you really have to say, my focus, my priority right now is maximizing my quality of life. That is my focus. It's not on doing every disease-focused thing that I can.
Okay.
If you have a urinary tract infection, those can be very uncomfortable. By all means, that hospice would treat that. And there are many things that hospices do that can be very aggressive, that are really for the focus and for the point of palliating any symptoms. But it really isn't for the point of prolonging life in and of itself.
And so we've talked a lot about how palliative care and hospice focus on the patient. How about the patient's family and the caregivers?
Well, as you know, I fell into, by mistake, learning about the issue of family caregiver burden. And I wish I could see everybody on this call and how many people here have heard of this issue, because I suspect it's a growing number. But to my slight embarrassment, I really only learned about it about 2 years ago, when I had already made a film, had gotten footage about what I thought was going to be the story of showing how beautiful death can be at home on hospice. And I watched the first rough cut of it before we started going into the editing process. And I said, oh my goodness, this film is not about a beautiful death. This film is about a family caregiver. And went on to learn about this rising public health crisis of family healthcare burden, family caregiver burden. We focus, hospices too, by the way, not just hospices, hospitals, doctors' offices. We focus on the patient. We're patient-centered, and that's great. We don't even think about that patient's going home to. Who is taking this patient to and from this hospital, this clinic visit? Who are we sending this debilitated patient home to, even with hospice on board? And what is their role going to be? And what's going to happen to this person? And the fact is, what's happening to these people is that they are suffering profound psychological, physical, and financial consequences because we are not supporting them as a society. All this money that goes into the hospitals and the hospital deaths, it's not going home when the patient goes home. And 2017 was the first year that more people died at home than in the hospital in 100 years. And if we're going to do that, if we're going to have that shift, and people are going to be spending more time at home, then we darn well better be supporting their caregivers, because we are going to have a serious problem. We're seeing it happen already. And COVID has given us a window into this, and it's really shining a magnifying glass on these family caregivers who are like canaries in a coal mine. They're already so on the edge. And then on top of it, to have COVID come and they can't bring in the help that they were able to scramble, a little bit of help here and there. They can't, and they're increasingly isolated. They're torn. They can't go to their jobs. People are quitting the workforce, women at a rate of 4 to 1 over men, because they have these caregiver responsibilities at home. And I'm not just talking about seriously ill patients that they're taking care of, but I'm also talking about kids. But this is a big problem. We have got to have a national reckoning with this, and we've got to put some safeguards in, because we're heading towards a very bad place.
It really puts such a burden on a caregiver who doesn't have medical training, and they're often administering IVs or cleaning or changing dressings. It's not just psychologically hard, but that strain of being so responsible. When do you call the doctor? When do you worry?
Yes, and we've lost that. It used to be that people died at home all the time until about 100 years ago. We would see people dying. We were comfortable with people dying. People died in your home, in your living room. It was part of life. We've totally become naive to that reality. And now we've got these caregivers untrained, unpaid, and completely unsupported. Even when hospice is in the picture, it's not there to support the family caregiver. And this is really causing, it's not only physically debilitating and financially debilitating, it's frightening. It's scary, it's lonely, it's a whole bunch of stuff that is very problematic.
Yes. In fact, maybe this is a good time we can show the trailer to Caregiver, a Love Story. And can you introduce it for us? And then Sydney, maybe you'll cue that up for us.
That's great. Sydney, make sure that it's the one that's 1 minute and 33 seconds. I think, Dara, you got that.
Yeah.
This is a film, again, about a really dynamic woman named Bambi Fass, who actually I knew, and she's a member of my synagogue. And when she was dying, she was doing everything. She was getting all the radiation and she was very aggressively trying to, and finally she called me one day, and she was so sick that I can't do this anymore. And we decided that day to bring in hospice. Within about 24 to 48 hours, her life had turned around. She was happy. People were, all her family was flying in from all over the world to come see her. She was feeling better. It was like, and her husband, who had been witnessing this terrible, what I call end of life conveyor belt approach, was relieved that, and everything felt like as a sad and poignant but beautiful moment. And so we brought in a film crew, because Bambi said, bring them in. If it's going to help someone else, let's show them how, just call in hospice and everything's going to be okay. And you'll see that her husband, Rick, just goes, you're watching him and you just see him taking a dive off of a cliff. And in this film, which is 24 minutes, it really covers 9 weeks of Bambi's 9 weeks on hospice, the last 9 weeks of her life. And really, again, Rick wasn't supposed to be a main character. He was supposed to be the guy who opened the door for hospice to let them in. And he became the main character. And it's all of the Ricks. There's 53 million Ricks out there. That's more than 1 in 5 Americans is doing this. So that's what this film is about.
I'm not going to say I'm not scared. Who doesn't want to just go to sleep and not wake up, Hopefully it'll just be peaceful and quiet and not cause too much pain to the ones I love.
We're just kind of thrust into the role sometimes, and you have to step up.
I knew the cancer was starting to take over. We weren't engaged yet, and I told him, this is your get out of jail free card. Next weekend he came out, pulled out a box. I didn't even open up the box. Just fell into his arms and said yes.
It was a pretty big decision because I basically had to leave work. How are you feeling? Are you comfortable? You're not in pain. I'm not trained for this, but this is the best thing for her.
How are you?
I'm hanging in there. It's a little tough, but I'm doing the best I can.
I'm hoping they're going to do is raise the methadone dose a little.
The decline has been more difficult than I expected.
What happened?
And I feel like my health is deteriorating with hers. This is a journey for the end of her life, and I want to give her the best care I can give her. It's all about love.
So beautiful and so heartbreaking, because all the things we talked about that burden a caregiver, the financial burden, the physical burden, losing the one you love is perhaps, of course, the greatest burden. Now, I'm sure for Bambi too, to see her husband going through all this was stressful, and people always say, I don't want to be a burden on my family. How do you help people avoid becoming a burden or avoid feeling like a burden? And then we'll talk about how we can help our caregivers.
Absolutely. Oh, I mean, this is the thing, you know, I don't know if you've ever heard of the game Go Wish. If you haven't, you should all go out and buy it. You can get, it's, I think, $7 online, gowish.org. But it's a game that allows you to sort of think about what's most important to you. What are your preferences and what are your values? And whenever I play this game with groups, not being a burden on my loved ones is always, it so frequently rises to the top for people. And Bambi says in a couple of places in the film, she says, there's one scene where I say to her, I said, how, she says, if I have to wear Depends, I'll wear Depends. And I say to her, Bambi, that's huge. You didn't want to wear Depends. You said that. And she said, it's just too hard on Rick. And there are several other things that Bambi was able to do because of who Bambi was. She's this giving person. And she's still, even when she was sick and dying, she was able to give back to Rick. Not everybody can do that. Not everybody will do that. But there are ways, if we prepare ourselves, this concept of advanced care planning in general, when we talk about, we think it's only about, do I want to be on a breathing machine or not? Do I want a MOST form? No, it's about all of the other stuff too. It's about, well, what if you don't want the breathing machine? You still have some decisions you have to make. You still have to figure out how you're going to handle the family caregiver situation if you're going to go home. Don't leave that to chance. So this is just another part of the picture of making decisions about the end of life. And I think it's really, really important because no one wants to be a burden. So think about how are you going to orient your family so that whichever one of you dies or is dying or is in need of support, you have minimized, you've figured out what kinds of things you can pull in for that caregiver so that they aren't just left there with no plans and no plans, but just falling apart. And I just want to mention that Stephanie Kushner, yes, end-of-life doulas. I want to put in a plug for end-of-life doulas. Big time. INELDA, which is the International End-of-Life Doula Association, is going to be, we're working with them to create a workbook around family caregiver burden. And I think that the end-of-life doula has such a role to play in all of this patient-centered experience that we should be absolutely, Joe Biden with your $775 billion plan, which is really, really great, should include supporting end-of-life doulas because they can make a huge difference in this experience for people. So thank you for bringing that up.
So I just wrote that for the attendees because that just came to the panelists, but somebody who is an end-of-life doula herself. So tell us what that means.
Well, I probably Stephanie could say it better, but end-of-life doulas, what's a baby doula? Everyone knows about doulas for people who are giving birth. They are advocates. They're advocates. They know what's happening. They've been through it many, many times. They're trained. They know what to expect, and they can help you through because they're your guides through this experience. Dying is also a common experience. More people die than have babies. So we should have these guides and advocates involved in the experience because they can do tremendous work for the people who are going through this the first and maybe the last time that they'll ever, I mean, this is something that can be of tremendous power.
So it's not a physician or a nurse. It's not someone with formal medical training. It's someone who has specific training in how to support families at the end.
I don't actually, I think that's true. And I don't know if Stephanie can talk, but I think that's true. They do get a lot of training. I just don't know exactly what it is, but it's just like I wish I had a doula from when I was birthing my babies. I certainly I would want to have a doula around if I were dying, if my husband was dying. I think it's really amazing to have somebody who's gone through this experience with so many people. I think it can be incredibly powerful.
I'm wondering if that's a California.
Stephanie wrote, no medical support person for patient and family, guiding, sharing options, eyes and ears of hospice.
I meant non-medical, sorry about that.
Okay, I was like,
non-medical support person. Thank you.
Great, yes.
Now, I'm wondering if this is a California thing, because I've never seen that in the Boston area.
Definitely not a California thing.
So it's national. Okay. And would someone look in the yellow pages? How would one find one of these wonderful doulas to help?
So there are a few directories. NEDA, National End of Life Doula Alliance, has a directory with doulas in every state. And you could find a doula that way. There are some, the University of New Hampshire, Doula Givers. There are a few places that do the trainings. ANELDA is also a place that does trainings and proficiency exams, all of which, you know, that I have done in the past, well, during COVID time, because it was the perfect time. So yeah, those are the places that I know there are directories. There may be other organizations as well that I'm not familiar with.
Thank you so much. Pardon my ignorance. It's wonderful. And I know here we more often would rely on a social worker or as part of the palliative care team, but it sounds like we need to think outside the box too and find whatever it takes to get the support we need.
Absolutely.
Thank you. Okay.
Thank you.
Awesome. And what advice, Jessica, would you have for family members trying to support patients going through this so that they don't burn out? I mean, it's very expensive to hire help. And in this era of COVID, as you pointed out, it's sometimes not safe or possible to have someone else come in the house. Sometimes you're just left with a very difficult situation. Any advice for us?
Yes, I have a lot of advice for you. And I'll tell you, we were given a grant to create an educational program that uses the film, Caregiver: A Love Story, for groups of caregivers, family caregivers, and it would go through organizations. Like we have the Family Caregiver Alliance in California. I don't know if that's I think it's national, but there's a lot of organizations, AARP, Alzheimer's Association, that have family caregivers who could benefit from watching this movie and getting some suggestions about what to do to make this a manageable situation. And so we created this program. The whole thing takes about 1.5 hours to 2 hours. And we've piloted it now. In fact, I'm just writing up the thing, and we're going to be sending it out to organizations, hospices, and other organizations that want to gather groups of family caregivers, and we'll let them use our movie and this program. But basically what we learned in doing a lot of research is there are a couple of different things that a family caregiver can do. First of all, there's what I call homegrown help. Think about Rick. People were bringing casseroles and that Maya, his granddaughter, wouldn't even eat, but they're sitting on the counter. They didn't even have room in the fridge. You know, what if our synagogue had organized who's going to do laundry twice a week? Who's going to take Maya out twice a week? Who's going to, you know, sit in the house so that Rick can go and get an hour of exercise and just a coordinated effort. We've got tons of committees in our synagogue. We don't have anything for family caregivers. And Rick, you know, part of the problem with family caregivers asking for help is that they all feel bad asking for help. They're like, I'm supposed to be able to do this. I'm the husband. I'm the daughter. I love this person. I don't want to complain. I don't want to sound like I'm getting burnt out. I don't want to. So there's this weird conspiracy of silence, which prevents people from getting homegrown help. So the homegrown help is the first thing. It's organize ourselves to help these people. Let's identify them and then organize ourselves to help them. The second piece is, do you know that there are tons of resources in local communities to support caregivers? They're highly underused. All of them are trying to figure out how to get caregivers to come and use their services. And they can't find the caregivers because caregivers are so busy and overwhelmed. So I think if we could figure out a way for doctors in clinics and in inpatient situations to be pinpoint, who are these caregivers, and then make sure that someone, whether it's the social worker, that there's some system in that outpatient clinic or that hospital that then directs this family caregiver or brings it to the family caregiver, because the family caregiver can't really do much, brings these resources that they may qualify to them and doesn't make them run around looking for it. But like, how do we marry those two things? There's a lot of stuff out there. We just need to connect it, the homegrown help and the resources.
And when people belong to a religious community or a synagogue or a church, I think you're right, that often works really well, although sometimes could use a little more nudging. But the people who don't have that built-in community, everyone's got a doctor, right? I mean, at least the patient who's sick has the doctor. So it really should fall on us to be proactive and not wait till people ask us for help, because you're right, they don't ask.
Or not wait until the person shows up, who you sent home on hospice, shows up back in the emergency room saying, now we're coming back, and now I don't trust you because you sent me home without preparing me for how terrible that was going to be. And now this person's going to go into the ICU and get on the end of life conveyor belt, which happens all the time.
Exactly.
So it's all not working.
There's a question here in the chat that says, how do you convince caregivers who don't want to relinquish control or accept outside help to do so for the sake of their own health and sanity? Asking as a concerned child, both for the parent who needs the help and for the parent who's caregiving.
Hi, Ariel.
Right? I mean, it's not funny, but it's common.
No, it's a very serious question. And a lot of this is why psychologists, I'm all into interprofessional. There's so many family dynamics are happening here, okay? So many family dynamics. And so what we've got to do is, there are a lot of things that have existed in families over generations or over the course of that whole family's experience that can get in the way of the caregiver experience because they don't want this. And by the way, preparing in advance for the caregiver period in your life will make it more likely that things will go smoothly. Thinking, well, what would you do if dad gets sick and you're all alone here? Then the person is like, okay, wait a minute, you're right, I'm going to need help. But if you're asking them to do it in the moment, like we're asking people in the ICU to make a decision in the moment, that's not the time. The time is in advance. That's why this is another form of advanced care planning that needs to happen. But I would say that, you might want to try doing things outside of the house. What are some things you could parse out that they're still responsible for, that you could just chunk out to someone else, that they might be willing? We, in our toolkit that I just described to you that we give to family caregivers, one of the things we have is a checklist of all of the tasks that you might be having to do, and what things could you parse out to somebody else, because there's always stuff.
There's always stuff. What about when the ill person lives alone?
Oh, yeah. Well, that's a tough one, because I'm assuming you're presuming that there's somebody across the country, the daughter calling on the phone. And by the way, the data is really interesting on that, because people who are family caregivers from a distance end up having more stress and doing more hours per week and spending more of their own money. It's really counterintuitive. I mean, there are some people who have, this is heartbreaking, but who really have nobody. It's rare, but they really don't have any family or people that they can rely on. And in situations like that, the reality is those people may at a certain point just not be able to care for themselves in their homes anymore, and need to have some sort of support in an environment that caters to supporting people. But for people who, have people helping from far away, it's a very stressful thing and can cause a much higher level of burden on the caregiver. So it needs to be planned out in advance. It's unique to each family.
It's so hard, I think, because it's so gradual sometimes, how somebody gradually loses the ability to be independent. And when an adult child kind of pulls the trigger and either moves that parent closer or moves there, sometimes it happens in a crisis moment, doesn't it? Because it's hard when you see or talk to them on a regular basis. At what point is enough enough?
Yes. And I'll tell you, the model that I have that I think is the closest to ideal is my mother-in-law, who died a year and a half ago. And she was always she prided herself in being very pragmatic and practical, and talking to talking to her family about what I'm going to do and how I'm going to be practical. And then, the truth is, when it really comes to that time, they're not quite, all of us don't want to really look our mortality in the face. And I think that, but at least there was that preparatory work that really, really made it much more receptive for the whole family and for her to really kind of move into the most practical approach to doing things.
So interesting. And somebody has said that we keep talking about mother-daughter, and would it be different as a parent-son? And of course, this was your mother-in-law. So you tell us, you've had the experience.
Oh, that's a really good question. And again, the thing that we always have to remember is it's impossible. Like, families are like snowflakes. Everyone is different and the dynamics are different. But that being said, yes, there are generalizations, and we know it from data. The fact is, women take on the burden of family caregiver significantly more than men do. Women who are family caregivers work significantly more hours per week than male caregivers.
I think there are definitely gender differences, and those translate into different types of stressors, and probably more stressors for the women, and particularly, quite honestly, minority women. And we're seeing this with COVID, people who don't have, necessarily the resources, like the education level, those people suffer more in this time of life. So it's very important for us to, as a civilized society, to think about who are the people who are suffering the most and make sure that we have things in place to support them.
Yeah. And do you have any sense of how the new president and government is going to make some changes for the good in that direction?
There was just an article on I have it on my list of things I have to read, that came out on November 27th in the New York Times. But Joe Biden is making a lot. Joe Biden was a family caregiver. He took care of his kids who were injured after his wife and daughter died. He had to be their caregivers. He took care of both of his parents on hospice in his home, I believe. He also had his son, Bo, and was a caregiver. It was involved as a caregiver with him. So he is acutely aware of this problem on a personal level and cares about it. And he has made a lot of it, both before he won the presidency and now his policy towards supporting family caregivers, mostly people who are elderly with serious illness, but also early childhood, people who have childhood responsibilities, those kinds of caregivers, all of us, is really looking pretty exciting. I mean, for example, the Family Medical Leave Act, which was signed in 1993, he was one of the people who signed it. It was considered a breakthrough, people who, and there were many caveats to getting family. You have to work in a place more than a year. The place has to have more than 50 employees, et cetera, et cetera, et cetera. But if you get qualified for family medical leave, it's unpaid. So now Joe Biden's coming back saying, we're paying these people for family medical leave. So there's one thing. He wants to give a $5,000 tax credit. He wants to increase by 150,000 the number of CHOW workers, community health workers out on the streets. Those are like end-of-life doulas. They're advocates for families with serious and complex illness. These are things I think really sound like they have some teeth. And I'm excited. I really want to take this film and show it to Joe Biden. I want to show it to Congress. This could be a cross the aisle issue. Family caregiver burden is a Democrat Republican issue. It's a white black issue. It's it's a rich poor. This is something that impacts the poor more, but it impacts us all, and we all need to take an interest in solving this problem.
Yes, and what you're doing is so important, because the first part is to make it a part of the conversation, right? And get people talking about it. Speaking of which, somebody asks, how do you bring up end-of-life care with your adult child? How specific is the conversation?
Great question. Again, every family is like a snowflake, right? But I talk to my kids about death and dying all the time. My kids are tired of talking about death and dying with me. And we talk about my preferences, my values. I talk about their preferences and values. I have on YouTube, I have a scene, not a scene, I went and played Go Wish with my at the time, I guess he was 17 years old son, and talked and learned a huge amount from him about what is important to him. He told me, I want you to keep me clean. I had no idea. I would have thought that cleaning him, if he was dying, would make him irritated. And I would have thought it would be a sign of disrespect, but he told me, no, I would want you to keep me clean and fresh. And I thought, oh my gosh, what a gift for you to have given me that. And then my mother has a hard time talking about this. My mother reads all of my stuff and, oh, that was a great article, but she doesn't want to really talk about it with me. So there are some things that I still really need to talk about with her. And as a daughter talking to a mother, there are all those fears of like, what if she thinks I'm trying to bump her off? What if she thinks that I don't care if she dies? What if she thinks that I want her money? I don't know. Whatever those things are that come up for all of us in having these conversations, you have to figure out how to get over them and have that conversation.
Well, I imagine for your kids, it's not that loaded to talk with you about your preferences because you're not sick in any way. But for your mom, it's really loaded and for you probably to talk to her. It's a whole different conversation.
The reason I think it's loaded for my mother, my poor mother's not, but I think it's because my mother, it's not because of her age. It's not because of her age. It's because of her. This is something she would have had trouble with at 30, 40, 50. And I think that some of this is really personality specific and generational.
So I think that probably, but you know, there's a lot of people who tell me in their 70s and their 80s that they're trying to talk to their kids, their grown kids about it. Their kids are like, I don't want to talk to you about it. Because they feel like, and it frustrates these elders because they say, I want to talk about this and this person won't talk to me. And I need them to listen to me because they're going to be the person standing at my bedside. And I think several people have said, well, what do I do? And I say, you need to look at that person, your 40-year-old daughter, your 50-year-old son, and say, I know this is making you uncomfortable for some reason. It would be a great gift to me if you would try to get over your discomfort and talk to me about it, because I need some comfort in knowing that you've heard what I have to say. That's what I
mean. And that's so straightforward. And with the goal of having them potentially be your spokesperson one day if you can't speak for yourself. Is that?
Exactly.
That's why they need to. So you're asking them to take on a bit of a burden for you, right? And that's hard.
You're asking them to be your advocate. You say, you care about me, you love me. I need you to be my voice when I cannot speak. And you need to hear me.
And that, I think maybe one thing that's helpful too for adult kids is to say, let's talk about it now when I'm healthy, when I'm well, we're relaxed around the dinner table. And this can change. It might change next week and you might have things as you think about it, and I might change my mind when push comes to shove. I might decide I do want to have a breathing tube, right? Because remembering there's nothing binding about a conversation.
Right. Absolutely.
Not even anything binding about a most form, but actually, and I should ask you before I feel like we could talk forever, and the hour's almost up, but we did have one email about a most form, and if you could tell us what a most form is, and then I'll read you this. Despite my mother's legal healthcare proxy stipulating no advanced technology, my dad would not complete the MOLS form for the nursing home. He said it's easier to make those decisions in a lawyer's office than at the time of need. So why do they need the MOLS form? And how do you overcome patient choice when other family members have to implement decisions in 2 weeks or less?
Okay, so here's the MOLS form. That stands for Medical Orders for Life-Sustaining Treatment. Some states it's called a PULSE form, which is Physician Orders for Life-Sustaining Treatment. Some states it's called a MOST form, Medical Orders for, I don't know what the ST stands for. Yes. Okay, so this is a doctor's order. This is very important to understand. This is a form that is an actual doctor's order that basically speaks to anybody that you may come in contact, whether they're an EMT, a paramedic, or an emergency room doctor, or an ICU doctor, or somebody in a place that could be doing something to your body. And it says, if you want everything done, full court press, you don't even need to worry about this because that's what we're going to do anyways. But if you, for some reason, decide, no, you know what? I'm at a place in my life, I have this illness or this disease, and I know that when my body starts to shut down, it is not going to be helpful for me to be put on a machine. It is likely to put me on this picture of this end of life conveyor belt, which I don't want. You need to get a MOLST or PULSE form filled out by your doctor that says, John Doe does not want a breathing tube. John Doe is willing to get this, but does not want that. It's the life-sustaining mechanics, those interventions that you either do or don't want. If you don't want some of them, you should fill out this form because otherwise it happens because that's the law. It has to happen, and people will do that because that's what they think and are legally allowed to do.
So the default, if you don't have this form, is that you call 911 or someone comes into your home or finds you on the street and they will resuscitate you.
Right.
So this form says, I don't want A or B or C. It might say, you can take me to the hospital, you can put oxygen on, but do not put a breathing tube, something like that.
There are some different variations, but if there's some piece of it that you don't want, you should think about and learn about the MOLST form. Now, in answer to the person, by the way, I have to lean down and plug in my computer.
Okay, go ahead. Bye. Okay, she's coming back.
Coming back. Ah.
And while you're doing that, the 5 wishes form I am going to put in there is a great form to get. I'm sure you know this. We've talked about the 5 wishes. The 5 wishes form that someone's asking about, you can Google. It's a great conversation starter for families about and for people to start thinking about what they want. But sorry, go back to the.
Oh, so the answer to the person talking about the father and what the mother has said and what the mother's priorities or what the father has said, that's a very, very tricky situation and very difficult, because probably in that family, the father is considered, even by this daughter, the person who gets to make the decisions.
The husband.
The husband. He's the husband. In California, by the way, we don't have this. So it's got to be the spouse, then the older daughter. We don't have that because California's got a different set of laws. I don't know what it's like in Massachusetts. It may be that it just follows this certain, starts with the spouse, then it starts with the adult children, in which case it is this husband who is the decision maker. And it is very, very difficult when you feel that you have heard someone's preferences and goals and they are not being documented, or sort of things aren't being set up to make sure that those things happen, and things are being left to chance. That is a very difficult situation, and there's no easy way to manage that. Again, there are decades old dynamics that could be going on there. I don't know exactly how that family, but I would recommend that getting some professional intervention, if he would be willing to talk about this issue with a family therapist, could be very helpful. And at the very least, the daughter, who's clearly suffering, should also think about getting some internal support, because that is a difficult and challenging situation to be witnessing for your mother who you love. And I can imagine how difficult that is. Yes.
Wow. Okay. My goodness. I feel like we're just getting started, but I'm afraid it's after 4, so we need to wrap up. But Jessica, I just want to thank you so much for putting words to these thoughts and fears and helping us start to formulate some thoughts. And we're going to send out after this to everyone who registered that list of resources again that has the links to the trailers, the link to your book, your Twitter and website and all that, because I think that again, this is just the beginning of some very important conversations for all of us. So thank you.
Oh, such a pleasure to be here. Thanks, everyone.
Thanks, everybody, for coming. We really appreciate it.